Welcome. Welcome. My name is Giacomo Grasselli from Milan, Italy, and I have the pleasure to run this discussion with you with Leo Heunks. You all know Leo from the Netherlands. This is a clinical challenge. So we have slides, but a very simple case. And what we want to do, well, we always say that, but let's try to be as interactive as possible. Okay, we want to give you simple clinical but important clinical messages, and we want to know your knowledge, what you do in your clinical practice. We are here to share knowledge, not to teach you how to do things, but please, let's interact. Otherwise, it becomes a lecture, and it's not intended for this.
I'm quite sure that a lot of you will not agree about what we are saying, so speak up if you do not. Okay, maybe we can start. This is just a very simple case. So this is a patient recovering from pneumonia on low pressure support ventilation, 6 of pressure support, 8 of PEEP. And I'm just asking, are you interested to know how much effort this patient is putting into breathing? Who's interested? Who's not interested? Who says, I don't care? No one. Okay. So why would you be interested? What do you want to know? Would you mind to speak up in the microphone?
Well, first of all, it depends on the patient clinical state. I mean, so effort can be something that can my patient might go bad with it. Might not be the time to have some kind of effort. I mean, it's not really true that we can't have any effort at all. So the thing is, how is my patient? Is my patient able to do some effort to be able to do some effort to breathe, and how he is going to move on with this?
So this patient was actually doing fine. He was literally reading a newspaper. Really?
The second thing is probably we have a cardiorespiratory system, so any respiratory effort has to take into account the cardiocirculatory ability to do it. And then what can make to my respiratory system. So if I get too much effort, it can be bad for my patient or for the lungs, and that's an important thing. I'm not saying everything so everybody can talk.
So you're raising two important points. So a high effort in this patient may be detrimental to the lungs and the cardiopulmonary interaction. Is there any other thing we worry about? Or any other motivation why you would want to know effort? Sorry.
Thank you for the time. I think bringing the patient to the pressure support CPAP stage, that's bring a question whether this patient is going to be weanable or not. And let's agree about the principle that putting the patient in the ventilation brings the plan for weaning rather than continue ventilating the patient. So this is going to be a step to assess the patient for weaning, and whether those parameters needed for the patient to continue with convenient respiratory effort bring the second question if this patient is going to be successfully extubated or he needs kind of bridging NIV or something post-extubation. So it's still kind of like assessing the patient and whether this is going to help for further plans.
Yeah, so to summarize, during spontaneous assisted breathing modes of ventilation, like pressure support, NAVA, or whatever, the interaction between the patient and the ventilator is very important, not only in terms of synchrony, but also in terms of quantitation of the assist. I mean, we want to avoid under assist because the patient will develop fatigue. We want to avoid over assist because the patient will develop muscle atrophy. We want to avoid self-inflicted lung injury. So the idea to quantify effort is to know how much the patient is pulling at each breath to avoid fatigue and to avoid the development of excessive volumes and transpulmonary pressure that can be harmful to the lung and that can have detrimental effect on the cardiopulmonary interaction on the heart.
I'm going to say it. Sorry, Giacomo, I don't agree here. Because anyone else who does not agree, or I'm the only one here? I think you raise an important point. And, okay, I'm not sure if patients on the ventilator can develop fatigue of the diaphragm. I think there's very, 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 very limited evidence out there to show that even if you fail a weaning trial, that you can develop fatigue of your diaphragm. Fatigue being something defined as a decrease in pressure generating capacity of the diaphragm being reversible after rest. That's the definition of fatigue, right? And it's not really the topic of this presentation right here. But think about it a little bit. If the diaphragm can really develop fatigue, but I still think it's very important to limit high effort, but I'm not sure if we really can develop fatigue of the diaphragm. Okay, let's go. So it's good to see. I mean, we don't agree. I'm not sure, I'm not saying that I am right here, right? I'm just a little bit careful in saying that the diaphragm can develop fatigue. The important point here is indeed, do you believe in that high effort can generate lung injury, the so-called self-inflicted lung injury? Do you believe in that concept? And secondly, do you believe in the concept that high effort, as Giacomo just suggested, can induce fatigue or injury? Injury is something different, right? Or injury of the diaphragm. If you believe in that, the so-called lung and diaphragm protective ventilation, I think is really important to assess diaphragm effort. If you're interested, I think these two papers where we contributed really nicely describe this whole concept of lung and diaphragm protective ventilation. So it looks like everyone agrees to quantify inspiratory effort. How are we going to do it? So what would be your preferred way of quantifying inspiratory effort? Can I first have someone else? Otherwise, yeah. Someone here? I mean, you all want to assess effort and...
One of the way which I saw in the Monza where Giacomo worked is determining of PEMUS index, for example. It's a very easy bedside technique and it's very useful, especially for ICU where a lot of beds and not too much doctors for some kind of sophisticated determining of pressure support.
So the PMI, pressure muscle index, we'll discuss that in detail later on. Very good.
Well, I'd say there's two aspects really. There's a clinical bedside assessment of what the patient looks like. I think you can't, ignore that aspect of their effort of breathing. But we use the P0.1 a lot on the Drager ventilators. I assume other ventilators do the same thing. There's obviously a lot of discussion about what is the right P0.1 because you don't want it to be too much or too low.
Right. So that would be your first choice to assess effort in this patient, P0.1. Okay. Anything else? So POC, occlusion pressure. So I think we have the three most important ones, right?
Yeah. Even though the golden standard is... Who is using the esophageal balloon here?
Well, quite a lot of people, actually.
Yep.
And I think, well, in clinical practice, honestly speaking, I think a lot of people are raising hands, and I want to raise my hand as well. And we're doing it every now and then, a little bit more than average, I think. But there's a lot of patients where you would not insert an esophageal balloon, and you're still interested in effort, right? So I think the esophageal balloon is the state of the art. As you know, during inspiration, pleural pressure decreases, and the decrease in esophageal pressure is a good estimation of the change in esophageal pressure. So that's the state of the art technique. If you want to use that one, you don't need the other ones.
And, yeah, this is just a theory, but occlusion pressure. Who is using POC? It's a very, very smart concept, I would say, because during an occlusion, you see, you know how to do it. It's an end expiratory occlusion, and you measure the change in airway pressure during the inspiratory effort of the patient against the occluded airway. The theory is very simple. I mean, during the occlusion, there is no flow, which means that there is no change in volume, which means that there is no change in transpulmonary pressure, which means that the change in airway pressure must equal the change in pleural pressure. So what you see there, the difference between the PEEP level and the most negative airway pressure swing is what is done by the inspiratory muscle of the patient. Okay? So let's assume that you start from 5 centimeters of water of PEEP, you go to minus 10 centimeters of water, your occlusion pressure is minus 15 centimeters of water, which is high or low or acceptable.
I think 7 to 15 is normal, right? 7 to 15 is normal. So this might might be a bit high then.
What would you say?
Yeah, I think I agree. Can I make one more note? So right here you see this patient on pressure support ventilation, right? Flow, pressure, and esophageal pressure. So with every breath while the patient is on the ventilator, esophageal pressure decreases. Right here, and right here you will perform the end expiratory occlusion. And as you can see, the decrease in pressure is a little bit higher than the decrease in pressure when he's just doing the tidal breathing under pressure support. So if you are really interested, I can show it here as well, otherwise you might miss it. So patient pressure supports breathing, flow, pressure, changes in esophageal pressure. So the patient is breathing, and right here we'll perform the end expiratory occlusion. And as you can see, the amplitude is a little bit higher as compared to just the previous breaths during tidal breathing. That probably has to do because there is no change in volume. It's more like an isometric contraction. So the pressure is a bit higher. If you are interested in the pressure developed by the respiratory muscles, you have to multiply this occlusion pressure by 0.71, 0.75. Right? So if your occlusion pressure is 10 centimeters of water, then the pressure developed by the respiratory muscles is
like
7.5 centimeters of water. So I think that's important to keep in mind. And this is a really, really simple procedure. Is this clear for everyone? I mean, you can do it on any modern ventilator.
Let's say that I test one and then adjust the pressure support, wait for a bit, but how long is a bit? How long do I have to wait before I can measure again?
Okay.
And see was it effective to correct for oversupport, for instance?
Okay, so her question is, if I measure occlusion pressure and occlusion pressure is way too high, I increase level of assist, how long do I have to wait to do another occlusion pressure? I think it's in a couple of breaths. This regulation is really, really fast. So if you wait for like a couple of breaths, you can assess, you can reassess.
So what are the numbers? Numbers?
We'll get to that in a second, if that's okay.
Okay, that's just the relationship between, you see, occlusion pressure and the transdiaphragmatic pressure developed by the diaphragm with the inspiratory muscles.
I think in the next slide it's...
Yeah.
So right here, and I think this is really important because what we just had in a kind of consensus, in the consensus paper, we would say if the pressure generated by the diaphragm for each breath is less than 3 centimeters of water, you are at risk for disuse atrophy. If the pressure developed by the diaphragm is higher than 12, you are at risk for load-induced injury. So this is what we assume, and it's very important because there is not extremely strong evidence out there that these are the best reference values. But if you believe, if you agree with me that we aim for a diaphragm pressure between 3 and 12 centimeters of water, then, if you look right here, if we take an occlusion pressure of 7 centimeters of water, the accuracy of the occlusion pressure is 92%. So, for the occlusion pressure, your limit should be between above 7 centimeters of water and below 15 centimeters of water. Again, this does not mean, and I think you have to take into account multiple things, right? It's not like if your occlusion pressure is 16 that, oh, you're killing the patient. It's not the case. But we clinicians like the reference values, and if you like the reference values, then I think between 7 and 12 is reasonable. Agree or?
Yeah, I agree.
Okay. So this is again very simple to measure your occlusion pressure. It is the difference between the level just before the occlusion and at the occlusion. Do we want to go into lung stress as well?
Well,
That's the time, or do we?
yeah, maybe we can
We'll
go to
skip
pure
it.
one. Yeah.
But the nice thing, if you go to the papers, with the occlusion pressure, you can even calculate the lung stress. I'm not going to go into detail, but your occlusion pressure plus the level of pressure support is an estimation of your transpulmonary pressure. So maybe you don't even need the esophageal balloon. It's not as precise, but it gives you an estimation of transpulmonary pressure.
And this is the PMI that she was referring to, which is measured during and inspiratory occlusion in spontaneously breathing patients. So it can be done, and now it's allowed in all ICU ventilators. So even in a patient in pressure support, or even during NAVA, you can perform an end inspiratory occlusion, and if the patient relaxes the muscles, which is the most important and sometimes tricky thing to obtain, if the patient relaxes the muscles, you will see a nice plateau pressure, a nice plateau in the airway pressure, which can be higher than the pressure developed by the ventilator. I mean, the ventilator delivers PEEP plus pressure support. If you do the occlusion, let's say that PEEP is 5, pressure support is 5, the ventilator delivers 10 centimeters of water. If you do the occlusion and you measure a plateau pressure of 20, it means that your muscles are adding 10 centimeters of water to what is given by the ventilator. Okay? Maybe we have here another. Okay.
So does everyone understand? Because when the first time I was reading this, it was quite complicated. So does everyone understand how the pressure can increase if you do an anti-inspiratory hold? Okay, you have been very clear.
No, this is, I think, a nice example. Yeah.
Can I ask a question about occlusion pressure? How do you measure occlusion pressure? Meaning 3 times average? Because in my experience, it's not always so. I do not obtain always the same number.
No, that's a very good point. So for the occlusion pressure, it is a single breath maneuver. So you just have an expiratory occlusion for one single breath, but a complete breath. But then if you really want to do a state of the art, you should repeat 3 times and take the average, I guess. It's a very good point because, of course, as we are sitting here, there's some variation in our respiratory effort. Yeah.
Okay, look this. You see here, these are 2 patients on pressure support, okay? In this patient, peak airway pressure is 20. Okay, so let's say that PEEP is 5, 15 centimeter of water pressure support. And in this other patient, PEEP is 5 and pressure support is 5, so peak airway pressure is 10. So if I ask you what is plateau pressure here, some would say here it's 20, here it's 10. But then if you take the end inspiratory occlusion, you say that plateau pressure is the same. And this is very understandable because if you have a certain compliance of the respiratory system and a certain volume, for the same volume and the same compliance, you need the same transpulmonary pressure, no matter of what is pulling the lungs, okay? So in this case, all the work is done by the ventilator, you see? While in this case, the patient muscle add this work and they have the same plateau pressure. So if the, which is 19. Okay, so the difference is that on the left-hand side, all the work is done by the ventilator, while on the right-hand side, most of the work is done by the patient muscles. And this is called the difference between plateau pressure and the pressure developed by the ventilator is called P-MUSC index or PMI, which is a reliable estimate, especially in patients with restrictive lung disease, not so much in patients with obstructive lung disease. It's a reliable estimate of muscular pressure, like esophageal pressure, okay, or occlusion pressure. But it's important to have a reliable plateau pressure, because if you don't see like a stable plateau, if you see a plateau increasing, you know, it means that maybe the patient is pulling with the abdominal muscles. So you have to make sure that the patient is relaxing the muscles, because this is static elastic pressure in the end, like plateau pressure during controlled mechanical ventilation, okay? So it's the elastic recoil of the respiratory system in static conditions. I think that now we have field one. Oh, no. This is for you because I am...
Okay, very briefly. So I don't think anyone mentioned it, but is someone using like ultrasound to assess inspiratory effort? I mean, ultrasound has become extremely popular, right? So you're using it. How would you use it? And what are your reference values?
Well, we don't use it always, but when we have a patient that repeatedly fails the spontaneous test, we try to assess the diaphragm function, and I always have to look at the reference, but I have a small yeah.
Okay, yeah, I completely agree with you. I think I would use like diaphragm ultrasound if a patient fails a weaning trial, just to quantify effort a little bit in a sense. Is this patient extremely weak or is this patient strong from diaphragm perspective? I think, well, for those with not that much experience with diaphragm ultrasound, as you know, every muscle that contracts thickens, right? So right here you'll see the diaphragm between these two lines. This is the diaphragm. And can you start the video, please?
Yeah, I can.
So this is a...
Yeah, I know.
I think you have to do it, Sarah, isn't it? Oh.
No. Now it's done.
Okay, right here. So during inspiration, you'll see the diaphragm thickens, right? And you can calculate a diaphragm thickening fraction in this case. So, and inspiration thickness was 7 millimeters and expiration 5. So you have a thickening fraction of 40%, which is nice, but we have to be very careful. Can we go to the next slide, please? Next one. Because this is very nice work from Martin Dress from Paris. And he investigated both in healthy subjects and in ICU patients that the correlation between thickening fraction and the pressure generated by the diaphragm is really, really poor. So I agree with you. I think you can use ultrasound just to find out if a patient has severe diaphragm weakness, diaphragm paralysis. But I don't think it's going to really help you in diaphragm protective ventilation. It's not really helping in assessing diaphragm effort. You agree, or?
Yeah, I don't even know how to turn on the ultrasound machine. So I have a bias because. Okay, so this is, just a summary.
Yeah, this is my clinical practice, but I think you would eye PMI, and now that I've heard it, I think that's important. That next Monday when I'm in my ICU, I would do the PMI as well, because I think it's important to add as many parameters as you can to assess effort. And if there's a discrepancy, you just think, why is this happening? Does that sound reasonable? Or?
Yeah, it does. And then we have PO1. Yeah.
Your PMI, when you see the difference at 10 centimeters of water, what are you doing? You increase the pressure support, or you
Well, it's more or less like with the PDI, like it's reasonable to have, let's say, a certain amount of work done by the respiratory muscles. So in the first case, if you have like zero or negative PMI, I would certainly try to decrease the pressure support in order to have to avoid atrophy. If you have excessive PMI, like above 7-8 centimeters of water, something like that, then I would try to increase pressure support to decrease the amount of work. But it's more or less. Who is measuring PO1? I slightly disagree with Leo. Yes, because Leo before said that PO1 is a measure of effort. It's like more a measure of drive. I mean, the difference is not so. The drive to me is more how much you want to drive to breathe, which translates in a certain effort, but certainly is not. There is certainly a relationship between the drive and the effort, but the drive is influenced by, let's say, sedation and so on. So the drive is something that is more influenced by your hunger, your how much you want to breathe. But anyway, PO1 is very, very useful, can be measured by any commercially available ventilator now. You can measure it by yourself during the occlusion maneuver, but the ventilator gives you a number. Sorry. Like, for example, in this case, this is a Getinge servo eye ventilator. You can see the number of PO1. Have an idea of the reference range for PO1? When you 1 to 4. No. 1, 3, 2 to 4. I don't know, something like. I would say 2 to 4. It's very, again, as Leo was saying, if you change pressure support, if you, increase it, if you do something to reduce the effort and the drive of the patient, like, you increase the FiO2, for example, or you increase pressure support, then you can measure PO1 almost immediately after you change the setting of the ventilator, because it's, again, the feedback between the respiratory centers and the muscles is almost immediate. So you can see immediately what's happening when you do something, like you increase pressure support and you will see PMI decreasing almost immediately. You don't really need to wait for a long time. Maybe if you decrease pressure support because you want the patient to work more, then you can measure PMI during time, because sometimes the patient is fine at the beginning of your trial and might not be fine at the end of the trial. But because he cannot, let's say, afford in time the reduction of the support by the ventilator.
Perhaps another important point here is that we're discussing the reference values a little bit, but it's very important. If you have a patient like with a P.1 of 7, the tidal volumes are okay, the patient does not have sensation of dyspnea, is perfectly doing fine, I don't think there's much, and the patient is improving, there's not much reason to intervene. Perhaps you can change pressure support a little bit, but I have heard and I've seen people increasing the level of sedation just because P.1 was too high. I don't think that's the way to go. Again, if it's just a P.1 that is 7, the patient is doing fine, tidal volumes are reasonable, all other parameters are okay, please, there's really, really insufficient evidence to change the level of sedation just upon that single value. And I think this is the same for the occlusion pressure. It's the whole patient, right? Sometimes when the occlusion pressure is high, but PF ratio is improving, patient's doing fine, we just accept it. If the next day the occlusion pressure is still high and PF ratio has decreased, it's just in the back of my mind. Is this a high effort? Is this high transpulmonary pressure? Perhaps now it is a good time to increase sedation a little bit. But again, just don't look at the reference values and act upon that. That's an important message.
Yeah, very important. If you have time, read a very short paper by Bob Bartlett. It's called The Old Man and the ICU. ICU. Read it. It's like one page. It's about an old man who is on the ventilator. He's developing like 1 liter of tidal volume, but he's perfectly comfortable. But people are around the bed and they say, no, okay, he's developing too high tidal volume. He's developing self-inflicted lung injury, so we want to sedate him, and he cannot say that he's perfectly comfortable. Read it. It's very interesting. I mean, of course, we have reference values, but we always have to look at the patient, as she was suggesting, because the patient who is in distress, you can say not only from the measures, but also from the clinical observation of the patient.
I'm afraid we almost have to close the session. Are there questions or comments you really want us to address?
A strong relationship between the main value and the trigger sensitivity for PO1? I don't think so. It's like PO1 is the first 100 milliseconds of an occlusion. It's not affected by the ventilator settings. It's like the ventilator measures the difference in airway pressure, how much you pull with your muscles during the first 100 milliseconds. So even if you have a pressure trigger, it doesn't care because you occlude, and then in that case, it's you who are pulling, not you're not triggering the ventilator. Santini.
A comment on the occlusion pressure, a question. The fact that it can be higher than the previous breaths, can it be because the patient becomes aware of the occlusion? Like P.1 was developed for this reason.
So that's an important comment. So you should not tell the patient you're going to do an occlusion, right? You're going to do it unexpectedly, and then it's nicely shown that it doesn't really, then it's not affected by what the patient is doing. So the increase in change in pressure is, yes, we're going to stop in a second. The increase in pressure is just because the mechanics are a little bit different when you're breathing in and there is a volume change versus not. Okay, I'm afraid we have to close. I'm afraid we have to close the session.
Questions.
Sorry for that.
Thank you.
Thank you so much for staying.
This.